So now I'd like to introduce Dr. Tinze Woreta from the Division of Gastroenterology here at Hopkins. Dr. Woreta is the program director of the Transplant Hepatology Program, is a world-renowned expert in chronic liver disease, specifically alcoholic liver disease, non-alcoholic fatty liver disease, and transplantation. And she is going to review with us NASH and NAFDL, particularly in our patient population of persons with HIV, and also discuss a study that she, Mark Solkowski and others are leading here for our patient population with NASH and NAFDL. So thank you so much for being here.
Thank you so much, Dr. Cheetah. I really appreciate you letting me come to discuss our study and the management of patients with NAFDL. And Dr. Sarkar from the Division of Endocrinology is also on, and we'll briefly discuss a study, a very innovative study that she's leading as well. So, all right. So can everybody see my screen?
Yes, it's not in presenter view yet, but we see.
Thank you. Let me put that in. Okay.
Yep, perfect.
All right, so just to let you know, I have no disclosures, and I'm going to briefly give you a background about NAFDL in HIV with a few slides, and then I'll delve into the study that we have that's open for enrollment. It's an exciting multi-center collaboration that we'll share with you today, and then also discuss the management strategies in NAFDL and the limited evidence that we have for people with HIV. I'll incorporate that. And then Dr. Sarkar is on again from Division of Endocrinology, and we'll briefly discuss this. I'll briefly discuss the SLIM liver study, which is an exciting randomized controlled trial that is open for enrollment. I just wanted to start with just reviewing the basic definition of NAFDL, just because it's going to be throughout the presentation. So just a reminder that NAFDL is defined as the presence of steatosis in greater than 5% of hepatocytes, and that's defined either by imaging or histology. And it's also important to remember that in the definition, we exclude secondary causes of steatosis, namely alcoholic liver disease. And it's subdivided into non-alcoholic fatty liver, where we have the presence of hepatic steatosis without evidence of hepatocellular injury, and a smaller subset of patients with NASH. And NASH is the presence of hepatic steatosis in the presence of hepatocyte causing hepatocellular injury in the form of ballooning, with or without the presence of fibrosis. So we worry about patients with NASH because they can progress to developing fibrosis, cirrhosis, and its associated complications, including the development of decompensation and hepatocellular cancer. The definitive definition of NASH does require a liver biopsy. So we'll discuss in many of the clinical trials, liver biopsy is the gold standard endpoint that's used. NAFDL is the most common cause of liver disease worldwide. So the global prevalence is 1/4 of the world's population. So it's a tremendous pandemic worldwide. With the availability of highly effective ART, chronic liver disease has become a leading cause of non-AIDS morbidity and mortality in people living with HIV. And NAFDL is projected to become the leading cause of liver disease in the aging HIV population. There is some data that the prevalence of NAFDL in people living with HIV is actually higher than the general population. So the general population, I mentioned about 1/4 of the general population. There was a meta-analysis published in 2017 estimating the prevalence of NAFDL in people living with HIV of 35%. So it is higher, and that's even higher in people with HIV with persistent liver enzyme elevation. And NAFDL is common in HIV-infected patients because of traditional risk factors, such as obesity-related insulin resistance, which is key in the pathogenesis. We know there's been an increase in the prevalence of overweight and obesity in people living with HIV. And one study found that almost 2/3 of a cohort of HIV individuals were either overweight or obese, and therefore at risk of developing NAFDL. But there's been evidence that even in the absence of obesity, there's other factors that may predispose people with HIV to developing NAFDL. And there's as in the general population, there is a population of people who have lower BMI that actually develop NAFLD. And the risk factors may include the direct steatotic effect of HIV itself, the high prevalence of insulin resistance as a result of ongoing immune activation, HIV-related dyslipidemia, and antiretroviral therapy may also contribute through causing drug-induced dyslipidemia and insulin resistance. Mitochondrial dysfunction was seen with the earlier generation medications that are basically no longer used, so we don't see that as a cause nowadays. And so this is just reviewing the antiviral therapy as a risk factor for the development of NAFLD. So again, the early generation medications that caused mitochondrial dysfunction and are not used anymore because of that, we don't see as often, but we know that boosted protease inhibitors, they do promote higher lipid levels, and there's some NNRTIs that have a worse profile for causing lipidemia and hepatic steatosis, like efavirenz. The integrase strand transferase inhibitors lead to improved metabolic profile, but we know there's studies that show association with the increased weight gain, so association with the traditional factors such as overweight and obesity that cause NAFLD. The problems with the studies that we currently have, a lot of the studies describing NAFLD in mono-infected patients with HIV, they were largely limited to single centers with small number of patients. A lot of the previous studies with hepatic steatosis, patients had concurrent hepatitis C infection. So until now, we were lacking systematic characterization of NAFLD in people living with HIV. And this led to the current study that we have, which is an ancillary study to the NASH, the Non-Alcoholic Steatohepatitis Clinical Research Network, or the NASH CRN. And for those of you who don't know, the NASH CRN is an ongoing research network. It's almost 20-year ongoing network that was started in 2002. This is funded by it's had continuous funding from the NIDDK, and the Data Coordinating Center is across the street at the School of Public Health. And Dr. Tanasha, Jim Tanasha, is the PI of that study, who's a biostatistician in the School of Public Health. And the work of the NASH CRN has resulted in many of the landmark studies that we have in NAFLD in adult and pediatric patients, and through clinical trials and longitudinal database studies which have been ongoing since its inception. The NASH CRN did exclude patients with HIV from the studies because they were thought to be distinct from the NASH in the general population due to ongoing HIV infection, antiretroviral therapy, concomitant medications, and coexisting infections. So because of that, we do have big knowledge gaps in our understanding of NAFLD in persons living with HIV in terms of even the prevalence, pathogenesis, risk factors, natural history, and histology, as well as therapeutics. So this led to the creation of the NAFLD and HIV study group, which I'm very excited to be part of. And Dr. Solkowski is also the PI in this group. This is an R01 grant that's funded by the NIDDK, which is an ancillary study of the NASH CRN. So it's wonderful because we can leverage the research infrastructure of the NASH CRN, which is a multi-center, 8 different clinical sites, to study this understudied topic in the HIV population. So this was funded in March 2020. It's multi-center, it's multidisciplinary. So it's a consortium of infectious disease specialists, hepatologists, immunologists, as well as using the expertise of the Data Coordinating Center at the School of Public Health with their expertise in clinical trial design and epidemiologic study design as well. These are the 8 clinical centers. So Dr. Naga Chalasani at Indiana University, who's world-renowned in NASH research, spearheaded the study. Dr. Solkowski is a PI, and so we're one of the sites. And Dr. Rohit Lumba at USD, who's also a very prominent NASH researcher, is the 3rd PI in the study. So you can see from California to Duke, VCU, UT Houston, UAB, the 8 clinical centers are involved, and the pathologists are the renowned pathologists from the NASH CRN who've really established the staging and grading system that we use for NASH. So, and the data coordinating center is still the Hopkins School of Bloomberg School of Public Health with Dr. Tanasha leading that. So we're hoping to examine key questions for this population. So we want to study the role of obesity, insulin resistance, and other components of metabolic syndrome, the impact of HIV infection and ART on NAFLD risk. We want to study the effect of alcohol consumption, which has been studied in the general NAFLD population, specifically in people with HIV, coffee consumption, genetic variants that have been shown to be important in the general population, the role of the gut microbiome, which is being increasingly recognized as involved in the pathogenesis of NASH, characterizing liver histology in the systematic way that has been done with the NASH CRN, and also looking at the non-invasive methods for assessing inflammation and fibrosis and their reliability in this population. And then finally, looking at the natural history. So there is some evidence that the natural history, there may be more fibrosis progression in this population, and then therapeutics as well. So for the therapeutic trials, I'll briefly mention some of the NASH clinical trials that are ongoing, but people with HIV have essentially been excluded from all the phase 3 trials. So it's important to have randomized trials, including this patient population for the future. You can see the number of patients, people living with HIV that you all may be seeing, over 3,000 at Hopkins, 65% are male, 75% Black, and 4% Hispanic. In some of the other centers, we do have higher representation of Hispanic population, up to 30% in the Texas and California populations. So this is a large multi-center sample that's really has multiracial ethnic representation, which will be important. Okay, so now moving on to the study. So we have one study that's actually open for enrollment right now, and that's our first study. It's the simplest study design. This is a study called Steatosis in HIV, and we are assessing the prevalence of steatosis in all comers with HIV infection. And so that's important because I mentioned some of the limitations with the earlier smaller studies, and so this will probably give more of an estimate of the actual prevalence. So this study is open for enrollment. We'd love for you to refer any patients you have with HIV, and I'll go through the inclusion criteria briefly on the next slide. The second study is a longitudinal study. So this is the first longitudinal study of people living with HIV with biopsy-proven NAFLD, and it's going to be a 3 to 5 year ongoing study where patients are assessed yearly and assessed for progression. And then the third study is the histology in HIV study, which involves our pathologist systematically characterizing liver histology. And then there is a randomized trial component, which this is not open for enrollment yet, but we will be evaluating the safety and efficacy of saraglitazar, which is a novel PPAR alpha gamma agonist in persons with HIV with biopsy-proven NASH. And so I'll focus more on study 1 and 2 because those are the ones that are open for enrollment. And so the first study, this is protocol 1, again, we'll be assessing the prevalence of hepatic steatosis in all comers with HIV. We'll be administering questionnaires to get information on detailed alcohol consumption and assess the effects of alcohol use on the risk of steatosis, as well as multiple other variables that we'll collect in this robust database. The inclusion criteria is pretty simple for this first study. Basically, it's an adult above the age of 18 with HIV that's well controlled. So they have to be on ART for greater than 6 months prior to screening with undetectable viral load at study entry. Patients, the exclusion criteria include patients with chronic hepatitis B, so anybody with a positive hepatitis B surface antigen. Patients who have core antibody positive can be included in the study, so that doesn't exclude them. Patients with evidence of recent or current hepatitis C, so patients who you've treated and they have had negative HCV RNA for 3 years prior to enrollment are eligible for enrollment in the study. and then excluding other causes of liver disease, and patients who can provide informed consent or undergo study procedures like the FibroScan will be excluded as well. Okay, so this study, again, all comers with HIV. We don't want patients who you suspect have NAFLD. This is just all comers with HIV without evidence of current hepatitis C or hepatitis B. You can refer for inclusion. This is a cross-sectional study, so for your patient, it's just going to be one study visit, and that's it for this first study. We do detailed baseline evaluation, so it takes, so far it's been taking a couple hours to go through this with patients. We are establishing a biospecimen banking at our Hopkins site too, where patients can they can consent to giving plasma, serum, and genetic sample for banking, and so that's something, but that is optional for patients. We have 7 questionnaires that we'll administer to the patients to get the information we need about alcohol consumption, beverage intake, physical activity, and this other information. So this study is open for enrollment. Please refer any patient with well-controlled HIV without hepatitis B or recent hepatitis C for screening. We do compensate patients for their time with a $50 gift card, which they appreciate if they are enrolled. And so feel free to contact me. That's my contact information. Right now we have 2 study coordinators, Lauren Stelmatch, who's on the call, and her email is there, who's covering for Quintara Williams, who will be back next month. And Dr. Arun Kumar Krishnan is also a coordinator for the study as well, who's also on the call. We're hoping to have the protocol 2 approved in the next month. And so this is the study of patients with biopsy-proven NAFLD, and we're going to be following them longitudinally. So this is the first study of its kind to follow this patient population longitudinally to study outcomes. We are aiming to have 400 individuals enrolled. Our goal is to test the accuracy of non-invasive assessments of advanced fibrosis in this population, determine if there's greater progression of fibrosis over time in HIV-associated NAFLD versus NAFLD in the general population, and maintain a robust biobank of plasma, serum, genomic, and stool samples. The inclusion criteria for this protocol 2 is the same as AIM-1, with the addition of the criteria that they do have to have histologically confirmed NAFLD. So this is the subset of patients with NAFLD in this trial. So they will require biopsy within 6 months prior to enrollment to be eligible for this protocol. And we're going to follow patients on a yearly basis. We'll take detailed intramedical history, medication changes, in addition to the same questionnaires that we administered initially to capture any changes over time, and the FibroScan as well. So the FibroScan will be performed at the baseline cross-sectional study as well. Our third study, this is actually ongoing, where we're studying liver biopsies from 400 people living with HIV with NAFLD, and this is involving our NASH CRN pathology committee, reviewing the biopsies, scoring them centrally, and assessing the similarities and differences between this population and the general population in terms of liver biopsy histological features that differ between the 2 populations. And then finally, I'll mention this study briefly because this is not currently ready for enrollment currently, but currently we're in the process of getting the IND. So this is the study of saraglitazar, which is the novel PPAR alpha gamma agonist that looks promising for the treatment of NASH. It's actually, this medication is currently approved in India for the treatment of diabetic dyslipidemia. And animal models do show robust efficacy in improving steatohepatitis. And so this is going to be administered daily for 12 weeks in an open label. It has been administered for daily for 12 weeks in an open label study to treat lipodystrophy-related hypertriglyceridemia already, and was shown to lead to improvement in triglycerides, HDL, ALT. And so based on that, this study is being submitted for approval, which is a placebo-controlled double-blind RCT. 160 individuals will be randomized to receive saroglitazar versus placebo for 72 weeks. The primary endpoint will be improvement in liver histology, which will be defined as a decrease in NAFLD activity score by more than 2 points without worsening of fibrosis. And that's been a standard that's been used in many of the clinical trials in the general population. So that's exciting. This will be one of the, as I mentioned before, all the phase 3 trials that we currently have really excluded people with HIV because of the concern for drug-drug interactions and other considerations. And so this will be one of the first clinical trials that we have available for patients, so therapeutic options. Now I'm going to briefly describe the management of NAFLD and the data that we have in patients with HIV. And so we do have limited guidelines just because of the limited small number of studies that we have, but recommendations are to reduce the degree of immune activation in HIV by introducing effective ART early, which may decrease insulin resistance. If patients are on antiviral regimens that have unfavorable metabolic profiles, they should be changed to one that's considered more favorable. When patients are referred to hepatology clinic, the two most important things that we do initially are rule out other causes of chronic liver disease. We get a lot of patients with NAFLD who are consuming above the threshold of alcohol consumption that you need to be labeled as NAFLD. So ruling out alcoholic liver disease, taking a detailed history, and counseling patients to stop daily alcohol consumption is important. And then the next step in evaluation is to really get an estimate of the stage of fibrosis of patients, because we know that fibrosis stage directly correlates with mortality in patients with NAFLD. The main targets for NAFLD treatment are focusing on obesity, which is driving the epidemic, focusing on the metabolic syndrome. As we know, insulin resistance is key in the pathophysiology of NAFLD. And then once patients have liver disease, decreasing steatohepatitis and fibrosis progression, and then finally minimizing complications like the development of HCC and cardiac disease, which is the number one leading cause of death in patients with NAFLD. So this is a summary of the current treatments we have available for NAFLD, and weight loss is really the backbone of treatment, and 10% weight loss has been shown in multiple studies to decrease steatosis in the liver, decrease steatohepatitis, as well as fibrosis in the liver. And so this is the backbone of therapy. This is often hard for patients to achieve. And we'll discuss briefly how we're trying to come up with more innovative ways to help patients achieve weight loss goals. Then we have treatments targeting the oxidative stress, which is just another step in the pathogenesis. And we'll talk about the role of vitamin E, and that has been studied in a small study in patients with HIV as well. And then pioglitazone has been studied, which is a PPAR gamma agonist, has been studied, and this is an insulin sensitizer, so targeting the insulin resistance, which is also a key in the pathogenesis. Important to recognize there's still no current approved treatment for the treatment of NASH, pharmacologic treatment for NASH in 2021. So this is, a big limitation. This is becoming one of the most common referrals to hepatology clinic, and weight loss is really the only proven treatment that we have in the absence of pharmacotherapy. And so to discuss the weight loss, there has been data that shows a low carbohydrate Mediterranean diet decreases levels of intrahepatic fat. So that is the diet that we recommend for patients, which is opposite of the Western diet, where we have high levels of fruits, vegetables, whole grains, low level of consumptions of red meats and sugar and sweets, and moderate consumption of dairy, eggs. And so one of the most challenging parts of being a hepatologist treating NAFLD is that patients do really struggle with achieving weight loss. So it has been proposed that given with the multiple medical comorbidities associated with NASH, that a multidisciplinary approach to treatment is warranting for treating NASH and decreasing risk factors. And so this involves not only obesity medicine specialist gastroenterologists, hepatologists, but also nutritionists, lifestyle coaches. So multidisciplinary approach to help patients succeed with achieving weight loss goals. We actually have this program that was started about a year and a half ago at our Green Spring Station campus under the leadership of Dr. Kim Gugini, who's in the Department of General Internal Medicine. And so this is the Johns Hopkins Healthy Eating Activity and Weight Program. And so we have a multidisciplinary team where we're seeing patients with NAFDL. I'm there as one of the hepatologists, as is our director of hepatology, Dr. Hamilton, with 6 obesity medicine specialists, and bariatric surgery is also part of our team. And so we're hoping that multidisciplinary approach will help our patients achieve these weight loss goals. And we're happy to see patients with HIV in this clinic as well, currently located at Green Spring Station, but we're hoping to expand to different sites as well. All right, so I'm going to briefly go over the data that we have for vitamin E for the treatment of NASH. And this was the landmark study that was established vitamin E as a treatment recommended by the AASLD in patients with biopsy-proven NASH. And they looked at the same endpoint as the clinical trials often use, which is a 2-point reduction in NAFDL activity score. And you can see vitamin E is this blue bar, which achieved 43% achievement of the primary endpoint compared to 19% of placebo. And this was a paired biopsy study. So because of this, the recommendation is to consider the use in non-diabetic patients with biopsy-proven NASH. Pioglitazone did reduce inflammation. Both vitamin E and pioglitazone neither achieved the outcome of improvement in fibrosis. So that's important to realize. There was a decrease in inflammation, but no change in fibrosis, which is a limitation because we know that fibrosis is what leads to the morbidity and mortality in patients with NASH. So this is just the summary associated with decrease in inflammation, which we see as decrease in transaminases, no effect on hepatic fibrosis. And it's actually not recommended by the Liver Society, the AASLD for diabetic patients, because they were excluded from that clinical trial. There's also some safety concerns. So there was an increase in all-cause mortality at doses higher than 800 international units daily, increase in hemorrhagic stroke, and increase in prostate cancer seen. And so we caution patients about the risk versus benefits prior to starting. Pioglitazone, which looked promising in the studies in terms of inflammation, decreasing inflammation, we rarely use in clinical practice because of the side effects of edema and weight gain, which can be detrimental to our patients with NASH. So this is the one study that we have in HIV patients of vitamin E. And you can see this is a small study, 27 patients. It was a single center, open label, single arm clinical trial. And patients were treated with 800 international units, which is the standard dosing, for 24 weeks, and then they were followed for an additional 24 weeks. And they did find that the 24 weeks of vitamin E treatment improved. So it led to decrease in ALT and decrease in CAP scores, estimating hepatic steatosis. But they also did not find any change in fibrosis in this small study. So we do need larger studies assessing the impact of vitamin E.
In the study you mentioned on pioglitazone and vitamin E, I think Chloe was just asking in the chat what the vitamin E dose was for this study.
Oh, that was 800 international units daily. Yeah. So,
yeah.
So that's why the guidelines in the AASLD recommend 800 units based on this randomized controlled trial with paired biopsy as the gold standard. So, all right. So then, okay, so that's, and I just wanted to remind everyone that cardiovascular disease is the most important cause of patients with NASH, which we know is a leading source of mortality in patients with HIV as well. So patients who, so that is important to address cardiovascular risk factors and be aggressive about cardiovascular risk reduction. And so this was the use of statins has been studied to see if it's beneficial in NASH. And basically the results show that it doesn't help necessarily with NASH, but there have been some meta-analyses that show lower risk of hepatic decompensation. So although it's not a specific indication for NASH, if patients meet criteria for initiation of statins, they should be started on it. So for patients with increased cardiovascular risk. Coffee, interestingly, in multiple observational studies has been shown to reduce all-cause mortality in almost all forms of liver disease, including patients with NAFLD. And so there's been multiple studies that have shown reduced risk of HCC as well. And so that's something that we're going to be assessing in our observational study, the effect of coffee in this population, particularly in persons living with HIV. So that'll be interesting to see if the same decrease is seen in this population. All right, and I'm just going to close with just discussion of what's on the horizon. So there's multiple pharmacotherapies, new agents with anti-inflammatory, anti-fibrotic, or insulin sensitizing properties that are being studied in phase 3 clinical trials for the treatment of NASH. I'm just going to briefly talk about two of them, obetacolic acid and semaglutide, which is being studied in phase 2 trials, just to finish up. And so obetacolic acid is a farnesoid X receptor agonist. Some of you may have heard of it because it's used in the treatment of PBC for patients who failed primary therapy. But it basically has anti-inflammatory, anti-fibrotic properties. And the phase 2 studies looked very promising, which led to this large phase 3 study that's currently ongoing. And the interim analysis for obetacolic acid did show that they achieved the primary endpoint of reduction in fibrosis stage with no worsening of NASH. And so this is currently being reviewed by the FDA for approval. And so this may be one of the first treatments that's actually approved for pharmacotherapies that are approved for the treatment of NASH. And so when you look at the actual numbers, 23% in the obetacolic acid 25 milligram group achieved the fibrosis improvement of 1 stage or more with no worsening of NASH, compared to 10 milligram group was 17% compared to placebo, which was only 11%. And so you can see some, modest improvement. And so the lifestyle modification is still going to be the backbone, because there's still a majority of patients who did not have improvement. Let's see. One of the common side effects that we see with obetacolic acid in clinical use is that it can cause dose-related pruritus, which was one of the most common side effects reported in clinical trials. There was also an increase in LDL that appears to be reversible, which was noted. So that needs to be monitored. All right, so moving to another area, the phase 2 clinical trial. So this is semaglutide, the glucagon-like peptide 1 GLP-1 receptor agonist, which has been approved for the treatment of type 2 diabetes, and it's being studied for the use in weight management, induces weight loss, and improves glycemic control in patients with obesity and type 2 diabetes. And in clinical trials in phase 2 studies, it has been shown to reduce ALT in subjects with obesity and diabetes. This was a study you may have seen published last year, which was a very interesting study published in New England Journal of Medicine, looking at semaglutide for the treatment of NASH. This is in the general population, and they looked at the primary outcome of resolution of NASH with no worsening of liver fibrosis, and they were randomized to different doses compared to placebo. And you can see the group that received semaglutide at the higher dose, 0.4 milligrams. They actually did daily dosing in this trial. They did have a higher odds of achieving the primary outpoint compared to placebo, and that was statistically significant, as was with the lower doses as well. So based on this, there's an ongoing phase 3 trial to look at this. One of the best things about this is that patients actually, they lose a significant amount of weight. So you can see 13%, the mean percent weight loss in patients in the semaglutide 0.4 milligram group versus 1% in placebo. And so the common adverse events reported were gastrointestinal disorders like nausea, constipation, and vomiting. There was some increase in overall neoplasms that were seen in the semaglutide group. And so the mechanism isn't entirely clear, but that does need further monitoring. And so the phase 3 trials are now beginning and ongoing. So that brings us to the SLIM liver study, which is a study from the AIDS clinical trial group. And this is a pretty exciting study because it is one of the first randomized clinical trials that is available for patients with HIV and NAFDL to be enrolled in. And Hopkins is a center led by Dr. Sarkar, who is now enrolling patients for this study. And it's a single arm open label study. And the purpose is to evaluate the effect of semaglutide on intrahepatic triglyceride content in patients with in persons living with HIV with central adiposity, insulin resistance, prediabetes, and hepatic steatosis. So this is actually funded by the NIAID, the National Institute of Allergy and Infectious Disease. It's multi-center. I counted at least, I think, 8 centers, including one in Brazil. So this is also a pretty large multi-center study, and all patients will receive semaglutide subcutaneously once weekly for 24 weeks, and then followed by observation for 24 weeks off the study drug. And this study is actually using MRI PDFF, which provides quantification of fat, precise quantification of fat to monitor that during the study. So this is another exciting study that's open for enrollment. Again, it's led by Dr. Sarkar in the Division of Endocrinology, and this is for contact information as well as the nurse study coordinator as well. So I don't know if you had any comments, Dr. Sarkar, anything. So you even started enrolling patients yet?
Oh, no, thanks, Tenzay. We have started pre-screening patients and are scheduling screening visits right now. So we've had interest from patients, and actually Tisha Henderson, who's our RN study coordinator, is on this meeting too. But we've been getting calls from patients who are interested in being in the study. So if you have patients who you think might be interested, please ask them to give us a call.
Excellent, thank you. All right, so just to conclude, since I think we're running out of time, I was trying to leave some time for questions, but the prevalence of NAFDL and associated mortality in people living with HIV is increasing because people with HIV have largely been excluded from studies of NAFDL. To date, we have large gaps in our understanding of NAFDL. So these are important studies. And so thanks again for the time. Please refer your patients with HIV for enrollment. The steatosis in the HIV study is open for enrollment. We've actually enrolled the first 2 patients. And again, that's just the baseline cross-sectional study, and your patients will be compensated for their time as well. The NAFDL and HIV database study will be hopefully open for enrollment next month. And then the SLIM liver study, Dr. Sarkar has mentioned, is open for enrollment in screening patients.
Thanks so much for that fantastic overview. And again, I think we're all seeing a fair amount of liver disease in our patient population. I think we have 2 minutes for questions if anyone had specific ones. Andrea Cox in the chat had noted that a regular MRI can provide a good estimate of steatosis. Do you see a movement away from biopsy towards MRI or other less invasive means of diagnosis like MRI PDFF on the horizon?
Excellent question from Dr. Cox. Yeah, so, I think the issue that we're having to get FDA approval, they really are insisting on biopsy data because, as you mentioned, the MR PDFF can give accurate estimate of steatosis, but the inflammation, the fibrosis staging, the liver biopsy is still considered the gold standard. So when we look at decrease in, NAFDL activity score, all the components are information we have in terms of biopsy data. So the non-invasive imaging is pretty good at detecting steatosis, and you can argue to some extent fibrosis, but then the actual inflammation that we have these precise scoring systems on that determine on biopsy proven, that's really captured best with biopsy. And so we all hope, because that is a big barrier for enrollment into clinical trials, that we'll be able to move away from that in the future. But right now, because of the capturing the inflammation in addition to fibrosis, that's still considered the gold standard. So.
So for example, I have someone right now that I'm working up for elevated AST and ALT and Allcause, which I suspect is going to end up being NASH, but we're going through all the the workup. But say we do the initial workup and it's negative and we do suspect NASH NAFDL, is it best to refer to hepatology for biopsy and longitudinal follow-up in the hepatology clinic? Or once you've looked at everything else, can you say probably this is NASH and just stop? Or what's the best next step once you've completed an initial workup?
Yes, and we do encourage referring to hepatology, just because we're hoping to be able to optimize the outcomes with some of the clinics that were like the multidisciplinary clinic, because we do find that the counseling, because we have such limited pharmacotherapy, and hopefully in the near future we will have pharmacotherapy to offer to patients, but we do find that referral, we've actually submitted this for a poster for ASLD, that there was, when we looked at patients and saw who attended the multi-D clinic and saw obesity medicine and hepatology, they did have a trend towards decreasing ALT when we followed them in a 12-month time. So there may be some benefit. There are some small studies that show the benefit of a multidisciplinary approach. So we do recommend the patients with persistently abnormal ALT and non-invasive imaging suggesting the presence of fibrosis, we do recommend referring them to us, because they're at highest risk for progression, and there's data that they're better treated in a collaborative manner than just by individual providers in terms of achieving decrease in liver inflammatory markers as well as weight loss.
And would you all tend to biopsy everybody where there's a concern for NASH? Is that the
In clinical practice for the general population, we don't, just because a lot of patients opt to not get it. And, because of the absence of pharmacotherapy, we don't really have, it won't really change the treatment recommendations. We do biopsy for patients when we're trying to exclude other competing etiologies, but the fibrosis assessment, we're mainly doing non-invasively. And then for people with HIV, because there's other causes that we're trying to explore, I think that's why in the context of these, epidemiological studies, we're advocating for biopsy just to better characterize it, and hopefully that may help guide the management for the future. So,
great. Thank you so much. Again, and I think people are commenting that this is a significant unmet need. I think one last question from Sharon Brinkley is, would you recommend a FibroScan to assess CAP score as a means to evaluate for fatty liver disease?
Yes, yeah. So that is, and we're going to be assessing specifically in patients with HIV whether comparing it to biopsy to show that whether it's just as reliable in the general population. But for now, we are we do recommend that, and we'll be assessing that specifically with this research study. I think there was one question about Spanish speaking as well, and we do have. We can get the informed consents in Spanish, so they will be we will be able to get that. I think our site currently doesn't have it, but if we find there's a large Hispanic population, then we can definitely ask our sponsor to we can actually add that to the IRB. In some of the other sites, that's already part of it in California and Texas because of the large Hispanic population, and if we come across that, we can certainly add that as well. So
great. Well, thank you again so much for taking the time to share this with us. And I'll just note Sherilyn's noting that we can FibroScan in our Bartlett patients every day, which is great. We are very lucky in the clinic. So thank you again for this fantastic overview. And it's very exciting to have all these studies coming to the clinic for our patients who, as you've said, been excluded from so many studies of this particular etiology. Well, thanks again.
thank you so much. Thank you.